Thank you and welcome all. So this is our March webinar for NHS Research Scotland Ageing, and I'm really delighted that we have Dr. Mathias Schlögl with us, who will be talking on psychological safety and empathy. But before we get started, we'll go through the usual housekeeping and other news. So in terms of housekeeping, I just want to remind you the meeting's recorded and archived. This is one of a suite of meetings to do. Please sign up for all of the future webinars. We're always looking for suggestions for topics, content, or speakers. So if you have any of those, do please let me know. Usual webinar etiquette, please cameras and audio off while the speaker is talking, and we'll have time for Q&A at the end. And I know many of you have heard this already, but I think it's always quite useful just to give a little bit of a context to this webinar series that we're running this year. Last year, I found myself in the position that I was effectively running 3 separate webinars for 3 organisations that I was chairing. So I was running webinars for older adult researchers, for dementia researchers, and for people with an interest in brain health. And as I looked at those 3 organisations, it struck me that there was tremendous overlap. And what I thought I would do this year is have some webinars that would be shared across the 3 groups and have some webinars that would be specific to each one. So here is the programme that we're running up until the summer. You can see that all of the webinars are on the first Tuesday of the month. The ones in gold are shared between dementia, brain health and older adult research. But then on some days we split, and we're having a split today. So today's talk is more geared towards people working in the older adult space, but I think will be relevant to everyone. And then for those of you who want something with a little bit more of a brain health and dementia focus this evening, we have another webinar from Hamid Haroon, who's going to be talking about living with a disability and being a neurosciences researcher. And you can see next month we have a shared webinar, and then we split again. So do please take a note of our different topics. I always use this first 5 minutes just to give people a little roundup of what's happening in older adult research in Scotland. There's a couple of things I want to tell you about. Under the auspices of the Brain Health Arc, we are running a multidisciplinary meeting. It's going to be in Edinburgh on Friday the 4th of April, and it's designed to bring together people working in the creative arts space with people who are working in the neurosciences and people who are working in clinical dementia or brain health. We had a talk last month from members of Scottish Ballet about the work that they're doing with older adults and people living with neurodegenerative conditions. And I think there's huge potential for the creative arts and for people working in older adult services to come together. So that is a free meeting. It's open to anyone. Details are there if you want to register. It'd be really good to see you at that meeting. Another date for your diary is our annual dementia conference. That is going to be on the 6th and 7th of May in Edinburgh. Registration isn't open yet, but again, that's a free meeting. It's always a really great meeting. We have lots of presentations, including from people living with dementia. So it'd be great to see you there. And then one other meeting that you can put in the diary, the Royal College of Physicians and Surgeons in Glasgow is putting on a meeting specifically themed around frailty. And what they're looking at is frailty in various parts of healthcare. So there'll be sessions on frailty in cardiology, frailty in surgery, frailty at the front door. It's now open for bookings. Their keynote speaker is Professor Chris Whitty, the Chief Medical Officer for the UK. So I think that's going to be a really great meeting. So that's your research roundup, but really what you want me to get to is the main event, our main talk. So I'm really pleased to have Mathias here. He is the Chief Medical Officer for the Geriatric Medicine Clinic and also Deputy Head of the Department of Internal Medicine. His research interests are delirium, palliative care, effective communication. And you can see that as well as his clinical background, he comes also with degrees, including an MBA and a Master's in Public Health from Harvard. So I will not delay any more because I know you're here to hear Mathias and not to hear me. So I will stop sharing my slides and I will hand over to our main speaker. Thank you.
Oh, I shared the slide. And please let me know if it works for you. Can you see it, everything?
That's
It's
perfect.
Okay.
Perfect. Yeah, thank you.
So once again, dear Terry, dear audience, it's a pleasure being here, and it's a pleasure presenting for you about a topic. Actually, it's two topics, psychological safety and empathy in healthcare, both topics which are very, very close to my heart. And I always choose opportunities like this to become better and learning from your questions at the end. So I'm very looking forward to this. My outline is straightforward. Number one, I would like to tell you why psychological safety is for me an absolute non-negotiable, especially when it comes in healthcare. Number two, I would like to convince you that empathy is a secret weapon for better outcomes. Number three, that it's not a skill, it's not a talent, what you either have or you don't have, but it's a skill which you actually can train. And at the end, I just briefly would like to tell you about an international mission I'm running right now with esteemed colleagues around the globe when it comes to psychological safety and empathy. So let's think about three cases I will present for you now, and let's think about what's the commonality on those cases. ChatGPT created the first picture. That's a nurse in the night shift. She works in the children's hospital, and she receives a note from an attending physician stating to give X amount of milligrams of whatever new drug the patient should receive. And based on her experience, because she does this for a couple of years now, she has the feeling that the order right now is absolutely wrong. But she will not speak up because the last time she spoke up exactly to this physician, he was very rude. He called her out in front of everybody, so she decided not to say anything, and the 7-year-old boy died in the morning because of an overdose. Number two, please meet Christopher, first lieutenant of a 777, experiencing some issues during the flight. And he senses that something is not right, that the captain of the 777 already made a mistake, but did not correct for it. He reported it on his notes, but he was afraid to speak up because the captain was known for his really harsh behavior. And 30 minutes later, the plane crashed against the mountains. Number three, a young assistant in a new upcoming startup. He's listening to a business case presentation where he senses that something is not wrong, that the numbers don't add up. Despite all the senior executives celebrating this new big deal, it turns out that exactly 3 weeks later, what he thought happened, that the numbers were wrong and they lost tons of money. So why is psychological safety now in healthcare non-negotiable? Relatively easy. Speaking up saves lives. And for this, I would like to point out the work from my colleague Amy Edmondson. She holds the chair for Novartis chair in business management at the Harvard Business School. And she, back in 1999, already stated that open communication and constructive handling of mistakes reduces errors and mistakes. And in the moment you feel safe to raise your concern, you have improved patient outcome. So fewer errors, safer patients. Isn't that what we want anyway? But even better, when we are able to speak up, it saves lives and we get stronger teams and better care. It enhances the teamwork, it enhances the collaboration, especially in a field like geriatric, where we live interdisciplinary, interprofessionally collaboration. It's necessary. And the moment we have a culture of openness, we have a better decision making, therefore, again, a better healthcare outcome and better problem solving. The other way around, in case we are not able to speak up freely, we get more medical errors. That's not the way we want like to have in our hospital. When you look from a healthcare provider perspective, your employees have a higher satisfaction at work, less burnout, less days of leave due to sickness. And importantly, when it comes to retaining talent, organization with high psychological safety retain talent better. So once again, psychological safety is not a nice to have, it's a must have. We get better idea, better creative solution, and we have a company, a hospital, an organizational award which drives on continuous improvement with the overall idea we would like to be better every single day for our patients and the families. So how can we do it? I would like to come up with 3 simple steps. Number 1, don't think about new task as a simple task of execution. Think about as a learning challenge. And for this, please also state, especially as a supervisor, that there are still uncertainty. That, for example, by treating the suspected pneumonia with the IV antibiotics, it still might be the case that the 85-year-old patient with a mortality of 25% in this age group might die. And that we have to point out that this area we're working in is highly interdependent. So we need the input from everyone else involved. It's not only the doctors, it's not only the nurses, it's also the physical therapist, and so on. Everyone's input is needed. How can we do it? Let's lead with curiosity. For those who are in the leader role, and it's not only the physician-in-chief of the hospital, it's also the residents. Also, the residents can lead with curiosity. Ask about the background. Ask about who might contribute. Actively seek feedback. Engage in open discussions. And that's very, very powerful, especially for those in charge. State that you sometimes have no idea and that you need help. It's a very powerful tool to state, back in the day, I made this error. And because of this, I learned a XYZ. Don't make the same error as I did before. Let's state what's not going well. And that's exactly what I have here with admit your own fallibility. We might be 15 years in our career, but that does not make us in any kind of way. No, I don't find the word. We are not without mistakes. We are not without failures. We are not without setbacks, despite the position we are in. And let's state that we are curious by learning, that we would like to learn, that we would like to become better, despite whatever high expertise you already have, because we still can learn. In my case, for example, right now, I truly hope that 1 year from now, I will look at this presentation with a different eye and have a couple of things already in my head, how I would like to improve it or already improved it. So it's a better presentation for the future. How can we do it in clinical practice? 2 things. Number 1, we could broaden the discussion. And I gave you a couple of lines you could use. For me, those lines, I always think about dancing. Dancing is very individual. So is the language as well. The first sentence might work for you, Terry, but it's not the second one or the third one. So you have to feel comfortable with asking this kind of question, what's fine for you? And in the moment it's fine for you, it's your movement when it comes to dancing, you will be able to bring it on stage when it's necessary. So it's one thing to broaden the discussion, but also to deepen the discussion. Curious by nature. What makes you think that way? I don't see where you're coming from. Please help me to understand. Give us an example. Go on, I'm interested to hear your thoughts. When you bring this up, what do you think might happen? I'm curious. Please share with us. One thing in my clinical practice, what I love, and I unfortunately don't recall from which literature source I have it from, is explicitly asking the youngest in the room. Because let's think if I would ask my deputy and she comes up with a very good solution for the problem, then I could give the feeling to the youngest in the room that their opinion, despite how big or small in impact, has no value. So for every single discussion I have in my department, I always start with the youngest. It reduces hierarchical bias, and they feel heard. The moment they feel heard, they will come up and ask questions. And I would like to share a story. I'm now here at this clinic for the 3rd year right now. And after like 9 months, I had lunch in our clinic, and from the left of my eye, I've seen a young 15-year-old nurse student looking to me all the time, and I could tell that she's nervous. And suddenly she stood up, came to me, and said, "Matthias, I have a question. What you explained during the rounds, I didn't understand. Please help me." And this moment was such a joyful moment that this young lady, who is around my patients 8 hours, 24 minutes, she sees the patient. She is important for the patient, that she had the ability to speak up. It was like Christmas and Easter together. So when we do it with the youngest, we enhance the learning. And if you especially do it with other members of the team, it fosters interprofessional collaboration. For me, as the leader of the team, I have to point out that every voice matters, and not only the voice of my staff, the medical staff, but for every staff, and especially from the youngest. So the critique could be that we have to sacrifice performance standards. And is it really a matter of finding the right point of a balance? Let's see, on the left-hand side, psychological safety, on the right-hand side, performance standards. If the psychological safety is low and the performance standard as well, then we are in the apathy zone. That's not funny at all. If the performance standards are low, but the psychological safety is high, that's the comfort zone. That's okay. But who wants to work with low performance standard? If the performance standards are too high and the psychological safety very low, then we are in the fear zone. So who would like to work in the fear zone? What we can do is we can set the tone and say, we expect the highest performance standards for our people in care and still have high psychological safety. And once I'm on holiday leave, I always see if my word is running when I'm not there, if the performance standards are still met, if the psychological safety is still high. It's not about me, the person Matthias, it's about the overall vision that you would like to have high psychological safety due to the reasons I stated at the very beginning, and of course high performance standards, as we do as medical professionals. Let's come to empathy. I call it the secret weapon for better outcomes. Why? Again, it enhances the patient outcomes, it reduces burnout, fewer medical error, higher engagement, and we can measure it from a clinical and from an organizational standpoint. This is a short, when you use the QR code, please do me a favor, look the work from my dear colleague Jeremy Hovick, who runs the Stonegate Center for Empathy Research in Leicester in the UK, which does amazing work. It's very inspiring. But the thing is, what Jeremy pointed out in this article, I think published in BMJ for 2 years, that during medical school, we teach the science, but not always the compassion. And over time, the environment erodes the natural empathy by focusing on simple biomedical knowledge, which clearly overshadows the emotional intelligence, what we need as healthcare professionals. Negatively, if it happens, unempathetic role models shape our professional norm. And what he also stated, the empathy training must be explicit. It is able to do it on a structured way, and it can be assessed. What Jeremy also does on a very high level is performing systematic reviews and meta-analysis. And what he clearly showed is that empathy reduces pain, anxiety, this increases the patient satisfaction, adherence, and practitioners with higher empathy scores see better clinical outcomes. So once again, why not invest in this? How can we do it? I stated it's a skill, it's not a talent. Jeremy investigated 26 RCTs, and the longest duration of this empathy training was about 12 weeks. And as I stated before, he could show that it improves the patient satisfaction. A very nice acronym he uses, or the literature uses on a regular basis, is the so-called BATHE model, a 5-step formula for empathic conversations. You see, it gives a background. You identify the emotions by asking, how do you feel about that? You pinpoint what the core is, what troubles you the most. You are genuinely interested in the resilience. How are you doing? How can you cope with all of this? And then you show understanding and support. So I would like to point out 2 things now. Number 1, and I bring this up later, the speed of the conversation. It's not our speed which is important. For the background, for the effect, for the trouble, for the handling, I always stated the question. But our sole responsibility is twofold. Number 1, asking the question, and then number 2, waiting for the response. It's like a ping pong game. You have to wait until the ball returns to you. It's not about speed, it's about adapting to speed of the human being in front of you. That's number 1. And number 2, when I state show understanding and support, that sounds relatively easy, but I would like to go a little bit more into detail with this. How can we do it? And I stated to Terry that I will provide slides in case that's necessary, in case you want them. What's very helpful in my clinical experience is observe non-verbal cues. Notice when the body language shifts. And you could do it with those sentences described below. It's very, very powerful. We can reflect the emotions back to the patient. And it's especially important that we name the emotions we see as a human being, as a suggestion, and allow the patient to correct if necessary. I'm teaching Breaking Bad news courses since 2005, so almost 20 years now. And ever since I used this approach, sometimes I have been wrong with my idea what the emotion might be, but then the patient is not angry with me. The patient says, no, I'm not frightened right now. I'm angry. I'm angry about myself, why I didn't go to my primary care physician earlier. So this naming the emotion as a suggestion brings us actually closer to the human being in front of us, which we want. And you can see a couple of examples. You seem frustrated. Would you like to share what's on your mind? That's an invitation, and the patient can accept or decline it. And then again, it's a ping pong sort of thing. State your idea and wait for the response. Mirror what you see. Sometimes they speak about others. And you can observe and state it. You've mentioned your daughter's concerns now. I'm curious, what's your thoughts? And what I'm very, very careful about is yes/no questions. And you might reflect yourself by raising up the career ladder. Sometimes just by the different position, you ask the same question, but you get different answers. I'm a young male chief medical officer of a clinic. I cannot always expect that in case I state a clear question which could be answered with yes or no, that I always get the answer which is really what the patient would like to state. I try to avoid it as much as possible and frame it as an invitation. What's your biggest concern? How has this situation been affecting you? And then once again, wait for what's coming. Paraphrasing is very powerful in two folds for me. Number one, it slows you down mentally, but it shows the human being in front of you that you care. And in case you summarized it wrong, which is possible, then it's an invitation to get corrected, which is good. Acknowledging emotions, again, please, without imposing your own view. State, I assume this must be hard for you. Maybe it's a language thing. In English, you always can say, I understand. For me, in German, if I translate it, I would never, ever state, I can understand what's happening to you right now. How can I, as a young physician who leaves by 6 p.m. and goes home to his family, who's healthy, how can I understand how it must feel being in a rehabilitation clinic for 6 weeks, 12 weeks in total, far from home? I have no idea. So our responsibility is to, by using the right words, to get rid of this disbalance of layperson, medical professional, old, young, sick, healthy, just by stating the facts the way we see it. We can train it. We can use role play. We could do the real world exposure, as you might call it, as early as possible, which very nice works relatively good for me. In my experience is the so-called reflective practice. Just write a 5-minute summary about what you've experienced, and it makes you think and what you might improve for the next time, and teach by example, and also show what's not working. Practical tips. I always hear, not always, but I often hear, I don't have time for this. Well, we could use micro-learning. I call it 5 minutes empathy drills. And for this, again, as I stated, the patient sets the pace, and this QR code is to an editorial I wrote for Journal of Palliative Medicine, where I state that it's not upon us to decide what speed we are using in our conversation. Let's think about relatively simple questions. How are you? We are using all the time. But just let's think about the idea that on a Friday we really have a bad week, and we are in Edinburgh running into an old friend of us who we went to high school with, and we haven't seen this friend for the last 10 years. Back 10 years ago, he was the best friend ever, but we lost contact. And he or she asked a simple question: how are you? So, familiar to this person, how would we answer? We would maybe say, I'm okay. But is I am okay the answer we would like to hear from our patient? I believe not. So what do those three pictures I will show you now have in common? You see here a young pilot doing his briefing or debriefing. You see here a young female nurse or doctor, whatever, scrubbing in. And you see here a young doctor contemplating about maybe what's happening next. What do those three pictures have in common? It's about mindfulness, about making yourself aware what's happening right now. And let's go back to this picture. A pilot who flies from Edinburgh to Los Angeles just not jumps into the 777 and starts the flight. He does a briefing. He checks how many patients are on board, the weather is, how much fuel he needs. Exactly the same thing for the nurse or for the doctor and for us. So please, we cannot argue that for a simple conversation, we do not have the time to prepare ourselves for what's coming next. So the next time we enter a room and I use the idea of the moment I touch the door, am I emotionally prepared about what's happening inside? Am I emotionally prepared about the fact that I have to observe better? The better I observe, the less I have to ask. Number two, we could do this, I call it the 3-second name and agenda rule, which you might recognize in a daily clinical practice. We sometimes forget to introduce ourselves with a name, with our role, and then simply state what you would like to talk about today. What's on your mind? Why is this powerful? Because it gives the patient the control when control is needed the most. Or we can do the 5-word active listening test. After the patient speaks, summarize it in 5 words or less. Again, think about ping, pong. You seem frustrated about waiting. It sounds like it worries you. Wait for the response. And the same here, as I stated at the very beginning. How can we do it? As I stated, I use the doorbell as a so-called trigger habit. I try to do it, making it team-based all the time. And I track the progress by asking my younger colleagues of making notes, a little diary note about what went well, what could we improve for the next time, what is a single step we could work on. Doesn't take a full day. And I always say it's a mental decision if we say, I don't have the time, or if I say, it's not my priority. You could show the RCT evidence, which I did, or you can use validated empathy scales for those who still don't believe it. There are a couple of validated questionnaires here for so-called patient-reported outcome measures, which is the gold standard. Just for you can look it up yourself. As I stated, you will get the slides from me afterwards. Yeah. And the last one basically brings me back to the very first, to the psychological safety. Admit fallibility, set the stage, and be genuinely interested about whoever speaks up, whoever brings their opinion, because sharing their opinion, as I stated, from this young 15-year-old nursing student, was a wonderful, wonderful experience. At the end, I just briefly would touch on the so-called Safe Care Initiative. Please find the QR code on the blog from the British Geriatric Society attached, where we state what the study is all about. It's an international multi-professional study group enrolling a couple of different countries. We did a survey, which I, in the moment, are analyzing, and we had 3 different goals. We wanted to explore the barriers and facilitators of psychological safety. We wanted to explore how communication, empathy skills might be the barrier in this process, and we would like to understand the challenges that healthcare educators face when implementing these elements. A relatively straightforward survey. We had roughly 250 responses all over Europe and the US, which is very nice. And then it's a start. So, my key takeaways. Psychological safety is a non-negotiable. We have fewer errors. We have innovation. Without innovation, there is no progress. Empathy isn't just nice. It saves lives. And empathy is indeed a trainable skill. And we can either say we do not have a time, or we could make it a priority to invest it for better care for our patients. This being said, you can see here the QR code, which is linked to my LinkedIn profile. I'm very happy that I had the opportunity to talk to you today, and now I'm curious what I can learn from your questions. Thank you very much.
Thank you. I learned a lot from that, so thank you very much for sharing. I see some people have joined and then left again, which brings me to my first question, which is about time. So, Mathias, a lot of what you were sharing was the need to pause, to give time for people to respond, to wait for that response. And that seems like the exact opposite of certainly where healthcare is going in the UK NHS, where we seem to be asked to do more and more with less and less time. And I just wonder, I see the value, but I also see the difficulty in trying to even find an extra second or two in our conversations. How do we get round that?
I bring again think about the pilot who sets the record straight not to set the record straight, who prepares himself for the takeoff. The better he is prepared, the better his flight will be. And this preparation doesn't take a long time. It's about what can I do? Let's say I stated about we have to prepare ourselves about the fact that maybe in this room, this patient might be delirious. For what key features in the room I should observe, because if I observe better, I do not have to ask the question. That's one idea. And that's simple for me, it's the trigger by pulling down the doorknob. That's number one. And number two is the research clearly states the moment we talk less, we are faster in the room because the patient has more the opportunity to really talk about what it's on his or her mind. Still, in my case, for example, I have 10 minutes per patient when I do my round as chief medical officer. And sometimes I get the information from my junior residents that this patient likes to talk a lot. And then I have to prepare myself and state already to this patient, Miss whatever Maya Huber, it's wonderful to see you. I apologize that I'm running late. Today I have 10 minutes for you. What's the most important thing you would like to talk with me within these 10 minutes? So by this framing, which took me 10 seconds, I set the record straight for the patient what to expect. And in the case, the patient, I get the idea that the patient still needs to talk and talk and talk. I can come back to my initial statement and say, look, I see you have a lot on your plate right now, as I stated before. Unfortunately, I only have 10 more minutes. Please do me a favor, summarize it with 3 little bullet points together with the nurses, and my junior residents come in the afternoon and go from there.
Yeah, I think that's a really good way to frame it. One of the things I loved about your talk was I picked up some little phrases that I think I may use in my practice. Now, I don't want to completely take over the questions, but I do have a lot of questions. A lot of your focus was clinical practice, and I know we have people joining who are coming from more of an academic background. It strikes me that a lot of what you're saying is equally applicable to chief investigators, principal investigators, people that are running a research team. What do you think?
Absolutely. Absolutely. This is also one thing why I desperately wanted to do this psychological safety project with the Safe Care Initiative. Let's just think back to my position when I started my position here 3 years ago. I've never been in this position as chief medical officer. I didn't have a deputy for 8 weeks. I had 3 junior residents running my clinic, just coming from out of medical school, basically having no idea. And I stated, and I had 2 teaching slots, Tuesday and Thursday, and all I taught was psychological safety back and forth. And my overall message was, in case you do not tell me, in case you have questions, we have a problem. I went to my direct boss with a lab results, which was a little tricky, together with my young resident in my first week, and said, Tom, I need your help. I had to show that I do not know it all. For the first 2 weeks, I was basically handshaking all the time because I had to introduce myself in the new ward. So yeah. It was absolute, and this really saved me back then.
Mm-hmm. Yeah. So hopefully we've created an environment of psychological safety where people feel comfortable to ask questions. So I'll throw things open to the other people on the call. Does anyone have questions? Just seeing in the chat, Professor Bettina Platt is saying, really interesting, thought-provoking, asking for help and admitting not knowing is a major issue. So an acknowledgement there from one of our senior researchers in Scotland.
Wonderful.
Any other questions from the audience? I mean, please do feel that this is a safe space to ask questions.
Yeah. I might have one question or one favor to ask, and you do. I wanted to use the Menti poll for this, but it didn't work. Please do me a favor and think about my presentation now like a lecture about how to improve our dancing skills. In case, so I danced a lot during my younger adulthood, and I always could train one posture. maybe the arms, maybe the legs, maybe the whatever. Let's think about one specific thing we would like to train for the next 4 weeks, and really only one. And we have to write it down now, because in 5 minutes out from now, we are busy again. So let's make it a priority to write one single task down, what we would like to do, what we would like to make a priority, teach it for 4 weeks, and then I truly believe it will be better.
I agree. I mean, I will share. I'm going to try a daily empathy drill. I'm going to try that for the next few weeks to see what changes are affected. So we have another comment here just in the chat. It's from an audience member who's actually in Scotland but visiting from Netherlands, and says, we learn a lot about reflecting in Dutch medical school, but is there a danger of reflection fatigue? How do people stay on top of this? How do they stay enthusiastic about it?
Yeah, well, I think it's, for me, I have two things in my mind right now. It's still be genuine. Also, as a chief medical officer, you can be tired and you can have a fatigue. You can state it and you can openly state it. That's one. And number two, when you think about the TED Talk, Simon Sinek, he's a very famous, he did the Start With Why TED Talk. He distinguishes between the finite versus infinite game. This reflection, this overall improvement idea is an infinite mindset. As I stated at the very beginning, I hope that in 1 year I already will be better. And 25 years from now, when I look at papers about communication I'm writing, I will look at myself and say, okay, interesting what this stage at your career you thought. And I hope that it will have improved by then.
Yeah. Continual improvement. I think that's probably a good place to start to wrap things up. I'll just double check. Does anyone else in the audience have any questions? If you want to raise your hand or pop them in the chat now.
Catherine is still typing.
And I'm not sure if that's going to result in a question or not. So it remains for me then just to thank Mathias again. I think that was an excellent talk, something slightly different for this session, but something that I think was much needed. So thanks all for joining. As I said, a lot of our engagement is actually online, and I think a lot of people are going to enjoy seeing your slides when we share them. I'll remind everyone this time next week next month we have a webinar again. The webinar next month at this time is going to be around evidence synthesis and how we can use new techniques in evidence synthesis to look at important problems for older adults. For people who want more webinar action today, we also have our Dementia and Brain Health themed webinar this evening, which is all about equality, diversity and inclusion. And Dr. Hamid Haroon will talk about working in neurosciences while living with a disability, which I think will be very interesting as well. But for now, just thank you again, Mathias, and thanks everyone for joining. Bye for now.
Thank you very much. Take care. Bye-bye.